Hello everyone and welcome to your Medicare Monday. In today's video I wanted to go over a little bit about how heart medications are now costing tons more money, how the kind of Medicare and the fee-for-service environment are changing, and how Medicare is thinking about changing the incentivizations of physicians that actually might hurt beneficiaries. And I'm going to talk about those things in today's video, so stay tuned. I hope it's educational. I've been always trying to make educational videos. If any of you folks out there have any kind of, questions or ideas that could help make these videos more educational, a little bit more entertaining, please do let me know in the comments down below or send me an email. I'll be more than happy to do what it is to help you folks on your Medicare journey. Okay, so first thing, heart medications. So congestive heart failure is something that many people unfortunately go through. My brother, he had congestive heart failure when he was 30 years old. He had some kind of the doctor said it's some kind of virus. Granted, he wasn't the healthiest of individuals either, so it could have been that. But he had some kind of bug. That's what doctors say. You know, CDC came down, pathology, whatever, they came down to make sure that he was cleared off of some unknown pathogen that could have caused heart failure, whatever. But what this article is saying is that the standard treatment for congestive heart failure is 4 medications. Now, upon looking at this article, I found that these 4 medications are very, very, very expensive. They show in this article that a 30-day supply for this 4 medication therapy is about $94. But oddly, at the end of this article, they say that most seniors are expected to pay about now $9,000 in total out-of-pocket costs, because these medications will push you all the way through the donut hole and into the catastrophic phase, which doesn't make sense to me. So later on in this video, I'm going to show you exactly how I calculate how much these drugs and things cost, so we can see exactly how these numbers are created. Granted, MedPage today, I have nothing against them. They don't run drug plan analysis like I do. So here they talk about that the cost of these medications are about 7% of the pre-tax income of most seniors, 50% of seniors. And if you were looking at the lower quartile of income, that's if you want to know quartile, so if we take all the people who are on Medicare and we take those who earn 25% of those who earn, in this quadrant of the 100% of people, you take the 25% of people that earn the least amount of income, that number jumps to 13% of their income. So if you have congestive heart failure, you now have a 7 to 13% budget eater that wasn't there before. In addition to that, hospitalization, surgeries, specialist visits, potentially physical therapy will all now be added to your treatment regime. And congestive heart failure does not go away typically. Normally, if you have congestive heart failure, as I know because I write a lot of life insurance, a lot of medical insurance, that is an uninsurable condition because it is lifelong. My brother, who is 30 years old, will most likely never be able to get a life insurance policy, period. He will never be able to qualify for a lot of health supplemental policies because of this illness. Even though right now he's healthy, his congestive heart failure is non-existent. He does have a little bit of AFib, but for the most part, you would not know that he had congestive heart failure based on his ejection fraction and other metrics for congestive heart failure. But he would never be able to qualify because of the diagnosis being on his medical records. So it's not something that you can just overcome is what I'm trying to get at. So here on this article, they say that many people have already paid their deductible $435. That $435 deductible is from 2 years ago. So, you know, or well, I guess it's from last year. So it's not even current. And they said that once drug costs have totaled $9,719, they'd move into the catastrophic phase in May through September. So you would be in the catastrophic phase in September, which means that you busted through the donut hole, you paid all this money. And in September, you'd be in the catastrophic phase where you still have to pay 5% of the drug cost. So that's September, October, November, December. 4 months of paying about 5% of that, or it's probably 5% of $100,000 at this point during those 4 months. And as it says here, the cost of medications, as well as the new cost of services, and the cost of the plan premiums that you're enrolled in do not have any effect or have not been studied in this circumstance. That's, to me, pretty terrible. But then again, they are lacking the available tools. So let's go ahead and see what the, I guess, Medicare Drug Finder tells us. I'm going to use my drug finder because I'm more comfortable with it, but for the most part, the numbers are going to be relatively similar. All right, so for this analysis, I'm going to use my happy zip code in Hawaii. It's just what I'm most familiar with. And I'm going to add these medications. Now, I just went and found this wonderful chart here of the medications. This is the actual full study that the article was referencing. And we have these 4 medications that one needs to take if they are newly diagnosed with congestive heart failure. So let's see if I can figure out what these acronyms even mean. So I guess Jardiance is one of them. All right, basic dose there. So who wants to guess how much this stuff's gonna cost? Holy moly. All right, so let's go to Walgreens, Longs, which is CVS, and gosh, can I get like a Times or something? Walmart. There we go. I don't like Walmart. I mean, nothing against Walmart, but I just don't like their pharmacies. I don't like the way they wrap things. Let's go at Safeway. Safeway is another one of those. Where'd it go? There we go. Safeway. All right, so we got Walgreens, Longs, and Safeway. Should hit all the major retailers. All right, go to plans, and we're going to go, of course, to the PDP plans because that's what we were looking at. And I guess the article did quote C, Medicare Advantage plans, but I don't like to talk about those. All right, so total estimated costs from now, which would be August 1st, would be $2,000. So let's go and look at most likely one of these plans because these are the plus plans. They cost more. Well, $69. We can look at both of these. So let's look and see how much post congestive heart failure inpatient admission will cost you. All right, so atenolol, inexpensive. Entresto, retail cost of $664. Yep, it's a little over $660 per month. Jardiance, also $600 per month. Kerendia, also $600 per month. Now, let's look at the total cost. So for someone who is signing up for Medicare Part D right now, your total cost with the drug plan premium and just these 4 medications, I'm not talking or thinking about any of the medications you currently have, it's going to be $2,000 for August, September, October, November, and December. And like I thought, when you hit the donut hole, which is a mere 2 months after enrolling, your drug costs now go up to $151 for Jardiance, $166 for Entresto, and the following month your Kerendia will be $151. and you will pay these costs all the way until the end of the year. And then when you go into 2023, most likely you'll be hitting a huge a huge surprise, as you will have a whole lot of payments until, like the article said, probably until September or July, it looks like in this one, because you're going to blow through it real quick with this concoction. But you'll hit the catastrophic zone where you're paying 5%. And just to do a quick calculation of what 5% looks like, 5% of, oh, my calculator came all the way up on this screen here. Let me go bring you back down. So if we take $664 times 0.05, you're still paying $33 a month for those 3 medications about. So you're still paying an additional $90 a month, plus your $69 plan premium for this plan, that is. And that is pretty crazy, right? That's crazy. Okay, so now we're already like 20 minutes into this video. Well, it's going to be less than 20 minutes because I'm going to edit out all the part where I'm looking for all this stuff. But that is how much heart failure is now going to cost with this quadruple therapy for Medicare patients. And hallelujah, all of this stuff, well, at least 24% of the plans will require a prior authorization for most of these medications. All right. Great. All right, so this article talks about healthcare desert. And it's talking about, I promise I'll tie it into the first article. It talks about how right now, Medicare fee-for-service physicians, that's everyone who is not in like an HMO, who when you go see them, they accept Medicare fee-for-service, and for PPO plans, usually they accept Medicare fee-for-service as well, similar kind of payment structure. And what they're saying is that these doctors, all of these hospitals, they profit on a very small amount of high reimbursable services. So you can think of like very complex surgeries give the doctors more money because they're very complex, right? More routine services barely pay physicians. I have a whole Excel spreadsheet where I talk about all the different types of Medicare reimbursements and what the normal reimbursement rate is for like a doctor visit, which might be less than $40 right now. So the doctor has a choice. You can either see a whole ton of people, like 80 people a day, just to pay the bills, or you can specialize and just do very expensive visits or very expensive procedures to make ends meet. And that's kind of where this article talks about maybe changing the incentive, changing the payment structure of Medicare will be beneficial for Medicare beneficiaries. That sounds good, right? Sounds good right now. But let me tell you what that is exactly like. That is exactly like all the Medicare Advantage plans that are HMOs. Now think about this. No one thinks about this, except perhaps those wonderful people who manage Medicare Advantage plans. If I have a patient, right, and Medicare is going to reward me for keeping them out of the hospital and healthy, but the way Medicare gauges out of the hospital and healthy is, number one, there's no hospital admission. They're not in an ER. They don't go to the urgent care, but they come and see me for their routine health risk assessment, annual wellness, advanced care planning, and end of life planning. As long as they do those things, they're healthy, they're doing their best, and we're managing all their chronic conditions. So what I can do is I can make it extremely difficult for someone to get in a hospital inpatient admission, because on a Medicare Advantage plan, those things are a prior authorization service. They need to get a PA. How do we do that on the original Medicare program? Well, original Medicare has what's called ACOs, Accountable Care Organizations, and DPC, something contracting, where they are pretty much run like an HMO. And then Medicare will say, hey, should this person go to the hospital? Yay or nay? And if it is financially beneficial for the organization to say no, they shouldn't go to the hospital, it's not that severe, they won't go. Medicare, these direct contract physicians and hospital systems will make more money because, well, you're healthier because you don't go to the hospital. Now, it's not that simple, but that's kind of the overview of it. And I'm generalizing, and I know that, and not all systems are going to be like this, but that's the kind of fear that I have. If we move from the fee-for-service model of healthcare that we have, which is not perfect, by the way, there's lots of problems. I get emails every day of all the physicians and all these hospital systems and social care and nursing facilities that fraud Medicare and Medicaid every day. That's not good. But like I said, it's not perfect. It never will be. It's run by human beings. Okay, next. If this happens and I just see it, the writings on the wall with federal government retirement and the United States Postal Service retirement all converging into Medicare next by 2025, this is going to be what the federal government's going to want to do to save money on the Medicare program. And I just think that it's probably not going to be the best. And I think what the best would be, or at least getting there, is direct primary care or concierge care, MDVIP, where you pay your physician a retainer. And that physician has, number one, financial security, so they don't have to worry about paying the bills. They are more concerned with helping you. Number two, if they keep you on and keep you going, keep you healthy, keep you alive for long enough, and keep your cost of medications lower, they still will get their retainer fee, and sometimes some of them will bill insurance for like a visit. So they'll still get paid. They still get their money. Physicians, many people don't know this, but most physicians do not get paid for prescribing medications. They get paid for running tests, perhaps, for having follow-up visits on seeing how you are on that medication, but they don't get directly compensated for, let's say, putting you on a really expensive medication, which is unfortunately some, I don't know where, but some kind of a miscommunication for many doctors and patients. The doctors don't get paid more for putting you on really expensive medications. That practice has been, I hope, completely made illegal. Before, it was something where the pharmacy company could, fund this house purchase of a doctor if they prescribed XYZ quantity of medication to their patients, but that's illegal. So from my understanding, that doesn't happen or cannot happen legally anymore. So most likely your doctor isn't doing that kind of practices. But what it does do is now doctors who now have to confine or are confined to this new quadruple treatment regimen for CHF, they have to now prescribe you these medications because these medications is going to be the standard for how to treat. It's going to cost a lot of money, cost a lot of, cause a lot of financial and mental stress for people who are on Medicare, because if you can tell, having a new bill of $10,000 a year, it's not fun for anybody. So what can you do to kind of, shave off or risk or figure out a way to divert this risk, right, by insurance? And that's kind of where when I did this video, I didn't know that it was so expensive until I ran the numbers. I literally ran the numbers live on screen. So what then can we do? Well, there's heart attack and stroke insurance, which I'm going to say isn't really helpful because congestive heart failure doesn't always result from a stroke or a heart attack, as in the case of my younger brother who has congestive heart failure without any of the strokes or heart attacks. So it wouldn't trigger the insurance to pay. There's no real congestive heart failure insurance that I know of, but the only thing you can really do is save money, and that's what I'm going to say is you have to be more aware that when you are in retirement or you are retiring, your financial planner, your retirement planning consultant, your insurance agent, whoever you're talking to figure out how much money you're going to need, not what kind of health insurance plan to buy, but the amount of money you will need. You need to overshoot it, and you need to overshoot it by means of having liquidity meaning money that you have that you can use toward paying for unexpected events. Now, normally we use insurance. That's where I would come in and say, look at this wonderful insurance product for you. But unfortunately, in this case, there isn't. So you're just going to have more money in an emergency fund to fund these drug costs. Congress, Medicare Part D negotiation, I talked about it in the Social Security video about how the Build Back Better Act has pretty much been shaved down to just two primary things, which is Medicare Part D negotiations and the ACA subsidies, which I honestly think will not pass. And the reason why is because to do a budget, to do any kind of budget toward Part D medications and to put a hard cap on Part D medications at $2,000 is going to require the plans to do some really, really creative plan design, which may hurt the beneficiary anyway, which may make the cost, instead of paying $9,000 in drugs, you pay $9,000 in medical premiums, right? That's going to be the kind of differentiator. And then they're going to have exceptions where these medications that are supposed to treat congestive heart failure are not in the plan. And therefore, the Medicare Part D drug plan can go into this wonderful loophole and say, well, we don't have the drug on the formulary. This is the Medicare approved guidelines on how to treat this treatment or this issue, and we have properly put these medications in, and therefore you might be taking some, I don't know, other medication that might not be specifically for congestive heart failure, but a swappable treatment to treat something else. Or any drug, any plan now that offers this concoction of medications would just have it really expensive, like really expensive, where you get knocked into this, like, I don't know, different category where you're paying now like $200 a month in premiums if you want this set. And if they have to do that for everyone, then everyone's going to suffer, because right now people who are really healthy can join really inexpensive plans, and people who are less healthy or have a more expensive concoction of medication can just join a more expensive plan. I foresee if this legislation goes through, all the plans will look like the really expensive plans, and then there'll be even more expensive plans to cover these kind of more expensive medications, because the money has to come from somewhere. And if they're only allowing you to debate or to negotiate 10 drugs a year, that's not where all the money is going. All the money is going to have to go to pay for these people, pay for the plans that are paying out more than, the $4,000 a year in benefits. It has to be recouped someplace. So more people who are on the cheaper plans will be paying for a lot more money. So what that means is the drug tiers are going to be trash. You're going to have tier 1 medications costing $40. You're going to have tier 5 medications costing $1,000. And you're just going to, boom, everyone's going to hit the $2,000 max out of pocket. Everyone's going to pay a more expensive premium. And that's just the way it's going to have to go, because there's just no money. Sorry, that was a huge rant. Anyway, I hope you learned something. Be sure to check out my video on the Social Security expansion. I talk a little bit about Medicare. It's in the retirement resources from this past Friday. I also have a video about the CPI-U, CPI-E, and the CPI-W, and the differences between the consumer price indices, and how really it's just a game. I don't even know why they really change it to make policy around, because if you look at it from the standpoint, if you want to fix what's wrong, that's not going to fix it. That's not going to fix it. Anyway, have a great rest of the week. Enjoy your week. Stay cool and stay dry. Do good things, and we'll see you later.